I think we're starting to have the potential to create unlimited abundance of clinical skills. We're a long way from there, but I think we have this potential. And that is
Mhm.
super exciting because for the first time, we have a tool that was never available to us through history of humanity that can get rid of this imbalance of supply and demand. And if we can get AI to provide an abundance of supply of clinical skills, then everybody has all the clinical skills they need readily available, to them, right?
Good. So, hello, Ali, and welcome to Impulse. I'm, glad you accepted my invitation to the show. I know you've been on, many other podcasts in the past. I think you're accustomed to the exercise, and I did listen to some of these conversations ahead of today, in preparation to make sure that we bring a different perspective to what has already been covered elsewhere. So I will ask you to introduce yourself, in your own words in a minute. Before doing so, I'll share, that you're one of the most, known health tech entrepreneurs in the industry. Certainly, an inspiration for me and for many people in the space. As I don't think there is, many figures like you who, let's say, have experienced the same range of, I would say, highs and lows, having, that you've gone through in your career. You've created, from scratch businesses that, reached an incredible scale internationally. So beyond England, where you're established, be it in, the physical care delivery space with Circle Health or in the virtual care delivery space with Babylon Health, a company that remains to me, pioneer in digital health and, to some degree also a company that was ahead of its time. There's a lot that's been, said about your work and your journey with these two firms, and you've already shared much of your experience and story in several outlets, as I mentioned earlier. So the idea for today is really to focus on your latest venture, Quadrivia. So it's one that you've announced, I think, early last year. We're recording this in September 2025. And to me, it kind of like embodies, a sort of panacea for AI in healthcare. So the listeners will discover it soon, but it's a kind of, to me, ultimate companion for patients and HCPs, at every step of the care journey. I'd like to understand, your vision for this venture, how you foresee Quadrivia, reshaping our relationship as patients and healthcare professionals to our respective health systems, and how we care for people, at scale. And I'm also very interested, to learn about, in let's say in simple terms, how it's being built, how it's being, certified, and the business model you intend to pursue with it. So I have many questions for you, and we'll try to cover as much as we can with the time that we have. And to get started, and as we do, at the beginning of every episode of the show, I would simply ask you, Ali, to present yourself.
Wow, you are not only charming and kind, and how can somebody say no to you? You're also well researched and have done such a great job. And it's so nice to see somebody doing their job so incredibly well. So, congratulations. I mean, seriously, fantastic. Um, Look, I'm Ali Parsa. You've been incredibly kind in the way you introduced me. The reality is, these things always sound a lot better than the truth. And I had my fair share of things I tried to do that worked and things that I tried to do that didn't work. That is life. That's what you have to do in life. We are unfortunately all live in a society, and with the advent of social media and the pressure of VC models, everybody needs to pretend that they are phenomenal and they're amazing and they're incredible. And the truth is, nobody's anything. We all try our best, but I built Circle. We had our challenges, Circle Health, but we had a vision, and our vision was: can we do hospitals better? Can we create places that people like to go to? Can we give the kind of care that we want to give to our family members? We had a very simple rule to all our nurses, all our doctors, said, let's just throw rule books away. Just treat people the way you want your mother to be treated, your child to be treated. And the hospitals is incredibly well in many ways. And as they did well, we were given more hospitals, and now today is the largest hospital group in the UK. I have no association with it. We sold it, and hopefully the people who own it now are doing as good a job with it. And then but as an entrepreneur, I figured out that hospitals are, if you want, are not very scalable. They're
Yeah.
very important, but it takes many years to build one. And they serve a small community around them. And people go to hospital for an acute or an emergency or a special case, but vast majority of your time you have nothing to do with your hospital. And we thought, well, with the and that was the time that mobile phones had come in, and the apps have come in. And around 2012, 2011, it was very clear that we could use these new devices that had all these capabilities to do something very different with. That was the time that Uber was coming in and said that I know where you are, I know where a driver is, I can connect you together. We were saying that, look, I think I can deliver most of the healthcare most people need and devices they already have. Like these devices create voice, create videos. Most doctors ask this. And that's how we created Babylon. At the time, most people thought that is rubbish. It's never going to work. A number of people were telling me, well, as a doctor, I need to touch, feel. Then I was asking them, how many times do you really touch and feel, right? And we're not saying we can do everything. We're saying we can do enough things. And it had its challenges, but it grew really fast. I mean, that company grew 400% a year every single year. And anybody who grows like that, it means there is a demand it's meeting. And the demand we were meeting was the demand for accessibility of healthcare. But accessibility, and our mission was to make healthcare accessible, affordable for everyone on earth, quality healthcare. And we figured out that as long as you deliver healthcare, most of the healthcare most people need on devices they already have, that's highly accessible. But that doesn't make it any more affordable. To make healthcare affordable, you need to understand where the true fundamental causes of cost are. About 50, 60, 70% of all our costs are in people. As long as our clinicians do everything, it will still cost a lot to deliver perfect because you have a very limited number. And the other costs are in about 60% of all our expenditure are on very predictable, very preventable diseases, chronic care management. Think about it, right? And and again, those can be foreseen and prevented or well if they are well managed. And we thought Babylon should do all of that. And that model worked really well. Now we fell for a very different reason. We fell because we chose to take the company public to an untried, untested model as a SPAC. And like every SPAC company that fell, Babylon fell. Now I read all this stuff. People say, yeah, it fell because of this, that, the other. Honestly, nonsense. Right. It fell because it went public. It had $350 million that was supposed to be paid to it. No fault of our SPAC guys. They didn't have the money themselves, so they couldn't pay it. Now we're public. The whole market is falling apart, going down. The share price is going down, so nobody wants to cover that hole. Quite rightly, too. You wouldn't do it. And then we had the debt holders who thought they can take advantage of the situation, own the company. Frankly, you might have done the same because it's the rational financial thing to do. For them, they thought they can own something very amazing for a small amount of money. Sadly, they couldn't pull it off, and the thing collapsed. But that's the lessons you learn. But but the objective didn't go away. So that whole thing of still, it is possible, in our view, to make healthcare accessible and affordable for everyone by making it available on the devices they already have that will make it highly accessible, and also by reducing the major drivers of cost, as I described it to you. And I think AI has a very big role to play. We tried it in Babylon at the time. But 2014, 2015, 2016, none of the technologies people are using
Yeah.
existed. We needed to bring it together to create things. Our AI team were fantastic, but they didn't have these tools. New tools have come in, and we think that we should have another go at this. I should actually rename it Babylon too. And and I'm incredibly proud of what we did, my colleagues did in Babylon, and the objective and the things. And maybe that's an idea. Maybe I should rename Quadrivia to Babylon again.
And so this is really what's driving your vision for Quadrivia. It's really to, make healthcare accessible to everyone, at a reasonable price. How has let's say, having seen how these, current tools that we use now every day, ChatGPT, Gemini, all the models and all these conversational tools that we use and that are very helpful, um, how do you see, or what is your vision for how these sort of like new tech stack can enable your initial vision that you have with Babylon?
So, if you actually economically think about this, the reason healthcare is inaccessible and unaffordable, I told you what its effects are, right? But the root cause was not that. The root cause is that in healthcare, you have an imbalance between very elastic demand. I get ill, you get ill, you do anything to fix that problem, to versus a very constrained supply. It doesn't matter how much I need to see a clinician, that clinician doesn't have time to see it, so therefore I can't see. Right?
Yeah.
Honestly, rule number one of economics, supply and demand, right? You have too much demand, too little supply, it becomes inaccessible and unaffordable. It doesn't matter what it is. I often say toilet papers, one of the biggest commodity things in the world, cheapest things in the world, became very expensive and very inaccessible during COVID when everybody jumped and tried it.
I never understood that.
There's a very simple equation, right? I and there is no solutions for that. We don't have universities that produce more. They should, but they don't have the infrastructure. It's very hard to get into it. And we don't have enough money in our education systems to triple, quadruple our number of nurses and doctors. So we can't do anything about this. But with AI, and by the way, the demand is only going to go up. We get older, we get fussier, we learn more. You know what I mean? We demand more. So very different. But with I think we're starting to have the potential to create unlimited abundance of clinical skills. We're a long way from there, but I think we have this potential. And that is super exciting because for the first time, we have a tool that was never available to us through history of humanity that can get rid of this imbalance of supply and demand. And if we can get AI to provide an abundance of supply of clinical skills, then everybody has all the clinical skills they need readily available, right? I need to say that we are a long way from that. I'm not in a camp that believes this can be done tomorrow, in a year, to this idea that just because AI can digest information and can regurgitate a new set of information back to you, that doesn't give it wisdom. Maybe one day people figure out how to give it wisdom. Wisdom comes with experience, with age, with ability to do. And I think, therefore, the doctors are and the nurses are super important to do that. And by the way, AI doesn't give you care, right? Often, you know what the problem is, what the solution is. You're going through it. You just need somebody to put their hands on your shoulder and take you through it. I mean, many people, not rich enough to do it, but many people have personal trainers. They can find on a YouTube what to do in a gym, right? But is that personal trainer's role is not to tell them how to lift a weight properly. Is their job is to motivate them, is to give them the human touch to go through the process. So I think there is a massive amount, AI is not going to replace this, but there is a section today of very specific, very routine, repeatable tasks and processes that clinicians have to do. And those routine, repeatable tasks and processes can really be done by AI. I have no doubt.
Mhm. And how does this materialize in your, having that vision for replacing that administrative burden and creating also that engagement towards, from patients towards their caregivers and their care system in which they evolve? Um, how do you go about designing a solution that can address that need?
So look, the solution is, I give you an example, right? I can even play you some of the AI if you want. Would that be of interest to you? Because
Yeah, sure.
um, um, I wasn't expecting to do that, so I don't have it ready in front of me. But let me see if I can find something and pull it out for you. Um, So, if you take a very simple conversation, imagine you go to surgery and imagine, uh, so that's a very big task, right? You go to the knee surgery. Actually, I can play you a knee surgery follow up tip, right? You go to a knee surgery. That knee surgery requires first the doctor or the nurse sees you beforehand and they call you, hey, are you ready to come in? Have you got any questions? Normally, before you go to surgery, two phone calls happens, right? For those two
Mhm.
phone calls, they probably try you 5 to 7 times before they reach you. Right. So that is about 10, 15 minutes time from the nurse to reach you to talk to you. Then maybe your knee surgery is only 1.5 hours, right? But then after the surgery, they usually call you 3 to 5 times to check on you, especially in United States. If they don't do that and you have complications and you go back to surgery, then
Way
of
of
course it's their
stuff.
cost, right? So they
Mhm,
call you
mhm.
just to check on you. Again, they probably have to call 3, 4 times to reach you. It takes 10 minutes, 5 minutes for the conversation. So a nurse that would have done the surgery and would have spent 2, 3 hours on the surgery probably have to spend another hour or two just on the pre and the follow up. Those are very repetitive routines, right? Those are things that actually they just need to ask you a bunch of questions to make sure you're doing well. And we trained our AI to do that work super well, right? So I can play you this is one of our people, but they were going through actually an actual case of a
Mhm.
surgery and the follow-up that was happening to it, right? But if you listen to it, it feels really human, right? I don't know if I can. Hello? Hi, is this Alex Smith? Yes, it is. Can you hear that? Hi, Alex Smith. I'm calling on behalf of Dr. Rice. I'm Kiyu, a clinical AI assistant, and I wanted to follow up after your hospital discharge. Is now a good time? Now's a great time. Great. How are you feeling after your knee surgery? I'm doing okay. My knee feels pretty stiff still, and I've noticed a bit of swelling. Some stiffness and mild swelling are normal during recovery. On a scale of 0 to 10, where 0 is no pain and 10 is the worst pain imaginable, how would you rate your pain? Pain is around a 4. But the swelling seems to be getting a bit worse, especially around my. Whenever you got enough, tell me. And you some. Have you noticed any redness, warmth, or tenderness in your calf area? Actually, yeah, a little bit. My calf feels a bit tight and sore when I press on. Thank you for sharing that, Alex. Are you experiencing any shortness of breath or difficulty breathing? No, my breathing feels pretty normal. That's good to hear. Have you noticed any changes in the color of your leg, such as it looking more pale or bluish? No, it just looks normal. Maybe just a little bit swollen. Have you been able to move your foot and toes normally? Yeah, I can move them fine. Have you noticed any drainage, increased redness? Anyways, you got the thing, and she will eventually
Yeah.
actually. There was a very clear case of something happening. She identifies it. She connects you to a doctor, to one of the nurses, real nurses, to call you back. In most cases, there is no problem. No one calls you, right? So this is
Yeah.
very doable. As a patient, you love it. Now the reality is vast majority of health systems don't have time to do this or money to do this. You live in Switzerland. In Switzerland, probably the system is not as such for people to call you back. In United States, they do because there is a penalty associated with going back to hospital,
Mhm,
right?
mhm,
50 to 60% of all going back to hospitals are highly preventable if somebody reaches out and finds something quickly. So, so it's a great example of something we can do today. It's not very complex. It's not very complicated, but it is also not very easy. And the reason we are not with this in the market yet and delivering it at scale, and the reason vast majority of clinical voice AI companies out there are not doing this kind of work a lot yet, is because two, three folds. One is that uh, health systems take time to build trust. There is a reason why the flat part of an S curve is flat. You have to wait a long time to win trust. There are companies, unfortunately, pressed by their investors at the time of the AI, and we can talk about this, all this nonsense we hear. Unless you're growing 1,000% a year, you're rubbish, you're not growing. These poor entrepreneurs, younger ones, hear that kind of stuff. There is pressure on them to grow, but in healthcare, you
mhm,
gotta be careful, right? I mean, you're in real world. I mean, this AI is talking to a real human being about a real issue, right? And they need to get it right. And we know generative AI is not deterministic, right? It is indeterminate. That's its beauty, but it's also its problem in a area like healthcare where you need to have sometimes a deterministic answer. I have to ask all the questions. I need to have the same answer for every one of them, so on and so forth.
mhm,
So I think we're at a place now that we can do a super good job. We're doing it with limited number of patients in the real world. We're learning. We're doing it more. Some companies are more aggressive with less data, less thing. They're going to the real world faster than we are. We think the way I think about it, every company I ever built took 10 years. And I think in 10-year periods, frameworks. And I just think that I'd rather be there in 4 years' time. What decision would I make today about the speed at which I deploy that will make me a bigger company, better company, more trusted company in 4 years' time than it does to?
mhm. I appreciate also that vision because I think there is this a bit of like we hear a lot about this AI race and everything is like evolving, very fast. And I mean, it's true. We see, models evolving and announcements and so on. But I think, putting it back into context of the healthcare industry and, how you are very experienced in understanding also like how hospitals, function. You've built many, many different ones. So I appreciate also having that, long-term vision and bringing back this sort of, grounding in whatever we hear these days. One of the things, when I looked at what Quadrivia on your website could do, and I think it's also related to the time that it needs to be, developed, validated, and certified, and so on, is that it seems like it's addressing many different use cases. So, for example, in the use case that you demonstrated and where we heard the system speaking. This is for post surgery management for one indication, and so you could imagine how about a cardiac surgery or oncology intervention or brain surgery. Like there's many different for the same use case. There can be an infinite number of indications to cover. And then if you extend that to additional use cases to do, prevention coaching, as you mentioned earlier, or to understand a bit what the symptoms of a patient is before there's a first medical encounter, that expands the range of things the AI needs to be capable of doing, and you know validated for managing these tasks. What's your take on
It's a
this?
really good question. And um, especially at the beginning, there was a lot of talk saying that, look, go do one single use case really well and then do more.
Mhm,
And you need to understand the incentive behind that. the incentive behind why you say that is, as you quite rightly say, and it's common, get something really right and then move on to the other thing. The problem with, and that was okay if you were building a workflow, because a workflow you have to build one at a time, right? Maybe you create a workflow framework and then you basically populate it one at a time. But the whole point of generative AI is it can talk to you about anything. I mean, actually, frankly, we limit Quadrivia Q from talking to you about anything. It can talk to you about your taxes, right? It sits on Gemini and OpenAI and can as easily talk to you about anything, right? So, so it makes no sense, right, to say because the technology is fundamentally different. Then it comes down to a very important question, which is our thing, which is how do you validate? How do you know it's done the right job? So we had to, in order to do that, we had to build a framework of we call them judges, like agents or judges who basically listen to a conversation in detail and say, has it done all its job, right? And then once it passes through all of that, then we have real human beings listening to it many, many times until the real doctors and nurses say, actually, this is great. We actually have a whole subsidiary business of nurses who sit somewhere in a country and just listen to these and dots. So, so with that, you would say, okay, in more limited use cases, but frankly, even the difference between asking questions on knee surgery versus elbow surgery, right, is a different parts, but it's the fundamental task is the same. Ask the following five, six questions and make sure those following five, six questions, if it's this, the answer is there, right? And uh, and these LLMs do a really good job at that. We learned how to moderate them, how to validate them, how to check them. So therefore, we can do a wider range. Why is it important to do a wider range? Because all the people who tell you only do a small range is because they're not. I mean, you have to put yourself in the real world where you are out there and then you're selling to your customer. A customer will say, that's fantastic. Like you can go through all the hassle of getting through a health system. 18 months, 9 months, 12 months process. You do that. The moment you do that, the next they come in and say, okay, that was fantastic. But I also have all the guys with the knee surgery and all the guys with the hip surgery and all the guys. Can you do that? And I say, oh, I'm sorry, I gotta go and build. Then you don't have a business. You know what I mean? Because each of these use cases are very small, narrow usage and it's revenue. You really have a business when it has everything. So we took a long time, and you're very observant to have seen this, to build something that is comprehensive and customizable across a very wide range of things to do. By the way, all of these things have one thing in common together. They're routine, simple healthcare clinical stuff. So we don't do administrative, we don't do complex, we don't do non-routine. So we are still super limited to about 20% of what a clinician does. The other 80% we don't even touch.
Yeah, interesting. And so you talked about certification, and my understanding of how medical devices are, approved and regulated is they are certified against an intended use. And so I'm thinking, if you have a system now that covers this, you know that range of use cases across multiple conditions, how do we go? Or I guess it represents a huge challenge to validate such a system, because you want it to be, as you mentioned, once deployed, applicable to many different possibilities or different scenarios. But to do that, you need to have the certification and the authorization to do it. And so I was really keen to ask you, how do you think, because I don't even know if like regulators actually know how they can
I can
manage
tell
this.
you they don't. I've talked to a lot of regulators across different parts of the world. I actually last weekend was spent the whole weekend with Bakul Patel, who used to be the head of FDA for digital health, and had many conversations around what he's gathering today from his old colleagues, and we were actually together when the White House announced that they're going to suspend and sandbox all regulation for digital health AI for 2 years. And actually, Bakul had written a paper asking for this to happen. And the reason for that is because every rule, all the frameworks that were built for regulating the digital devices or medical devices
Mhm.
do not apply to healthcare, to AI. They just don't. But in Europe, in some parts of the world, particularly in Europe, but also a little bit in the United States, we have built an industry of regulators and consultants and advisors, all of whom get fed out of this business, right? So they all are talking really fast and hard about we need to regulate, we have these mechanisms, so let's just use them. And of course, if something doesn't fit, that means more consultants need jobs, more people need to get things done, right? I mean, so they're happy, right? They make a lot of money, right? Every company needs to have a clinical this and a this, that, and a that. Therefore, they lobby more for this to happen. The result is Europe has fallen completely behind in AI. That's just the reality, right? And the Americans have
Yeah.
said, you know what, we're not going to go down that route. We're going to win it. The Chinese and the Asians have said the same. Middle Easterns have said the same. So really, Europe is just the odd one out right now. It is not for me to say which system is the right or the wrong one, right? We need to just follow regulations in both, right? So in United States, we
Yeah.
can do far, far more. Therefore, we put a lot of resource. We can bring more and more of Q's capability. In Europe, we are limited in UK we're limited to giving information and receiving information. But we can't really analyze that information. And where we get our medical device certificate, class one, is for that limited use. We take that, right?
Mhm.
Um,
Mhm.
it's a very big issue. You put your finger on something super important. I was born in Middle East. Up to the 15th century, the Middle East was the cradle of science, mathematics, knowledge. I mean, especially down 11, 12, 13, 10th century. And before the Islamic world, it was the Persian world. Huge progress there. But somehow around 15th century, it stopped because when the Gutenberg press was invented, the Europeans embraced it. People like Luther used it
Mhm.
to
Mhm.
bring this debates of philosophy and religion. Scientists use it to circulate scientific ideas, innovations. But in the Middle East, the sultans and the mullahs turned back and said, sorry, this is blasphemous. If you use it, that means the word of our religious books can be replicated by other people rather than us giving it the teaching. The sultan said this is dangerous because other political views can be circulated. And the people who used to write to the Quran and the books said, look, this takes our jobs away, right? As a result,
Mhm.
just didn't happen in that part of the world. Knowledge didn't get circulated the same way that it does. And to date, less books by far gets translated from English to
Mhm.
Persian or to Arabic than it does to a small nation like Spain, to Spanish, right? If you think about it. So I think it's a very big issue. I'm not a politician. It's not for me to decide. It's for us to follow the regulation wherever we are. But all I'm observing is I am
Yeah.
seeing where AI is taking off, and I'm seeing who is talking about it but doesn't have the courage to actually deal with it. Look, the current regulation doesn't work. Simple. The current regulations were built
Mhm.
for if that, then that, right? And that's really simple, right? If this happens, then this happens. If this, then that. With AI, it's not like that. If that, many things can come out. It's indeterministic. It can give you any answer, right? There is no way if you have a conversation with ChatGPT or with Gemini today, let alone with Q, you know exactly what the answer of every question is going to be.
Yeah.
So we need to decide. We ban it in healthcare. They don't have the courage to do that. They talk about we want AI everywhere. Or we have to say the regulatory environment says it has to be deterministic and I have to know exactly what the answer is every time, is not applying here. Which one do you do? Have the courage, make the decision, get it done.
Mhm.
So people in Europe, my fellow entrepreneurs in Europe, know what they're doing in the same way that my fellow entrepreneurs in the United States or in China or in Asia or in Middle East do.
Yeah. It's interesting. I had a conversation in this season of the podcast with Dr. Ricardo Batista Leite. He's leading the Health AI Regulatory Agency, Geneva. And so he has a very interesting, I think the concept he was bringing to the conversation that I think he's pushing for in all his interactions with governments, with health systems, is to use, post-market monitoring the same way we use it for drugs, for AI-based solutions. And then you just you follow, what the outcomes are, and then you make the decision on whether a solution stays in the market or not based on, and not based on a list of requirements and a level of control you cannot actually guarantee by the way the solution is made. So yeah, I'm also go. I mean, I support your view on that matter. Um, on another topic, and going back, to how Q is working. One of the questions I had was, I think medical practices, vary quite a lot from one place to another, even within the same country. And so I wanted to ask you how you go about, making Q and the system that you want to deploy, um, kind of like customizable to different care practices. Is this, I think it's something that you are considering for sure, based on what I've read. But I wanted to take the
So
opportunity
you're
to.
absolutely right. I think every two doctors will do something very differently. And every health system does things differently. Countries do things differently. Uh, I think it starts from the very principle of what are we training here and what are we creating here? Are we training, creating a piece of software, or are we trying to create a support to a human being? And I think those two are very different. I don't think you create AI, intelligent AI, the same way you create a software. I don't want to pretend he's a human or is intelligent, but it's a replacement for a human interaction. That conversation you just heard, or many others I can play you, if I don't tell you, hey, I'm Q, you wouldn't know whether it's a human or not, right? And it's trying to do the job of a human. In that world, I think all our mind framework should change and it should think that way, right? That I am, so what would a human do? If I was going to get an assistant who was a human, would I give them to do a single job that they can only do? Or does this human being has the choice to go and work for another doctor or another part of my hospital who want me to do something different? What do they do? So if I'm a nurse or I'm a resident and I go for a senior, work with a senior doctor or senior nurse, they say, hey, Ali, call all my patients and tell them the result of the lab is okay, right? And if they have any concerns, answer it, right? Now, I have the ability to answer any question because I learned medicine, so I can answer it. For instance, if I was a resident. And I also have the ability to call these people, so I can do the job. Another doctor comes in and tells me to do the same thing, but they say only give them good news, the bad news, just let me make a phone call. Okay. As a human, I know how to do that. I'll do that. Another doctor comes in and says, you know what, Ali? I want you to call all my patients and just take their history. They're all coming to see me tomorrow. 10 minutes of my time is going to be about taking them. You take history, summarize it, give it to me so I can just check quick things with me. As a resident, I can do that, right? So if truly AI Q is going to be a clinical assistant to every doctor, every nurse, it needs to behave like a true clinical assistant would have, right? And that's what we need to build.
Hmm. Yeah, I'm looking forward to seeing this when it's available.
By the way, it's
Actually,
available. Huh? I
especially
can
with
give you
the
access.
around.
You can play with it. You can see how it works. It makes a phone call to you straight away. It's already making phone calls in the real world to the real patients. But we're going super, super slow in the real world with this because because you know what I mean. One mistake is too many. By the way, it's a very good debate that
Yeah, yeah.
one, which goes back to your regulatory debate. As I said, I was in India and I was talking to one of the leaders in the health group, and people were saying, in third tier cities in India, according to United Nations, only 40% of consultations are accurate. And the reason for that is there is such a shortage of doctors. And these doctors have such a huge queue of people. Sometimes in a single shift, they see 70, 80 patients, right? So they only have 2, 3 minutes, right? With the patient in average. What's wrong with you? My head hurts, take an aspirin, right? I'm exaggerating, but that's. But so we know that,
Yeah, yeah.
right? And we also know that the best doctors on the most complex diagnostic work, they are about 80% accurate, right? So we also know that. And so the range is between 30, 40% to 80, let's just say for super, super doctors, 90% accuracy, right? What if we built an AI that was 90% accurate all the time on all its conversations? Should that AI be deployed to everybody? It's a very interesting question, right? Because if it is, we've basically given an assistant or an AI that is as good in that, but again, I emphasize that narrow task it does, not the entirety of what a doctor does. In that narrow, routine, repetitive task is as good as any human doctor and better, right? So it's not actually at human level, is at better than human level. But you go to a clinician and say, look, I do 1 million interactions a month, 10% are wrong, and the newspaper picks up 100,000 mistakes are made a month. Not the fact that in the normal world, 300,000 mistakes are made, 500,000, 400, but this is 100. Do we go, is the headline, we improved 400,000 mistakes to 100,000 mistakes? AI made a improvement on that? Or is the thing that 100,000 mistakes were made, right? So now it's invariable, inevitable. AI makes mistakes as humans do. The question becomes the severity of that mistake. So if I'm talking to you and I've misspelled your name or mispronounced it, that's still a mistake, but it's not a life-threatening mistake. I think we need to get to a point where we are very sure life-threatening mistakes are not happening. We don't see it happening, so it's reassuring, but we should grow it slowly in the real world to make sure it doesn't. And we should do these simple cases to start with, and that's what we're doing. But you understand the complexity in this, right? I mean, there's a very big,
Yeah, yeah.
very big, very major uh, AI agent, clinical agent company. Everybody, you know their name, I know their name. These guys' accuracy level, they say, oh, our accuracy level is 95%. And that's under lab conditions in real life. I hear about 30% of calls lead to a human intervention, one way or another. They claim they make 100,000 calls a week, right? That's 30,000 calls that need another human being to call you. 30,000. Which call center of which hospital can make 30,000 extra phone calls? So actually, they're creating unnecessary work for people by. Is this a good thing? Now, for the company, it's a good thing. The numbers are growing, but the customers are suspending the operation or putting it off. They're not adding it up. So be very, very, very long term greedy, but do not allow other people's interests to force you to do something too fast before it's ready.
Yeah.
Totally.
Yeah. And so according to your, sort of like long-term plan, by when do you think Q will be deployed in the real? I understand it is already deployed or being deployed, in certain scenarios in the real world at a reasonable, like a very controlled pace. By when do you foresee to be available to a broader
My hope
level of
is
the
that
population?
we're currently making tens of phone calls, right, in the real world, because we can listen to it, we can examine it, we can do it. And these are clinical concourse, not like scribing. And by the way, there's a massive difference. People say, look at AI, it does scribing. Scribing is not what we do, right? Scribing, you listen to something anyway. ChatGPT does it. I don't really get it, right? You then transcribe the conversation. I mean, this conversation between you and I can be transcribed on anything, right? And then it summarizes it, right? Okay, describing companies make it to summarize to the way you want, right? Done. But at the same time, then you as a doctor or a nurse check it, and then you okay it, you're fix it, and they say their accuracy rate is 80%, right? So you change things. People say, look at Lovable. It's been amazing, right? How many apps Lovable has built that you have to rebuild, redo, right? And it's also nice kind of demo, but you can't deploy it in the real world. So it does something with AI, autonomous agentic clinical AI, real time. You're doing something very different. There is nobody else checking. There is no one else. It's a it's a real time conversation. So we need to deploy tens of other AI agents to listen to every conversation at that time, safeguarded, rail guarded, make sure it doesn't do something wrong, so on and so forth, right? And that is a very difficult scientific engineering task that we are solving. I think the results are really good. We're doing tens and they're working well. Soon we'll do hundreds, then we do thousands, then we do tens of thousands. I mean, that's the way you go. Uh, but we're super confident that that this is gonna work really well in a real way, without giving the burden to our customers that look, we've made a phone call, but we didn't close the problem. When I say we make these calls, we close the problem, right? Nobody else needs to intervene.
Yeah. Oh, that's my hope as well. I'm keeping an eye on the time. We have like 5 more minutes, and I know you have a hard stop on top of the hour. What resources would you recommend us to, check out to, to learn more about the
Uh,
field in which you work? If you
I,
have
I
some
kind of figured out
suggestions
that
or
I am just not bright enough, intelligent enough to keep up with the barrage of things that are happening. I just hire really clever people in my team. But I honestly, there is a new paper coming out all the time. Like you and I were talking about deterministic, indeterministic.
Mm,
Last week, I was reading a new paper that the former CTO of OpenAI's new company, Thinking Lab, just published, which actually claims that they solved the deterministic AI problem, right? Now let's see whether that works, right? There's so much happening so fast in this space. Keeping up to date is the role of the professionals. For us enthusiasts,
mm.
which our job is to hire them and let them get on with it, but also make the judgment of what is ready for real market and what is not. Yeah.
Yeah. Mhm. Makes sense. Can you share with us an anecdote from your work, at Quadrivia that made you realize the impact that
Yes,
you
I mean,
have on people's lives?
we
Yeah,
announced
they-
we were doing work with Modality, which is one of the largest GP practices in the country, and with various things. Really interesting. We started with something super simple with them. But the moment they saw the effect that what it can do, then one single use case is now about 25, 30 use cases they want to do, right? Each GP, each doctor, why doesn't it do that? It's fantastic to see. As I said, in a few months' time, hopefully, we will get many, many things done. Now, we're that company operates in UK regulatory environment incredibly hard. But if that company was in United States, we'll be doing thousands of phone calls with them right now, right? So as we're going into the US, our
Mhm,
customers
mhm.
there are asking us to do things they desperately need very fast.
Understood. If you would recommend a fellow healthcare innovator as a potential guest for the show, who would that be and what would
For
you
your
recommend her
show,
or him?
it's a really good question. You're a technologist, and it's a show that is for people who are interested in technology. Uh, I met her and I loved her so much I hired her immediately. It took me a bit of time to persuade her to join us, but she eventually did. I would talk to Rebecca Love. She's a nurse, wonderful in her job, understands AI, but can tell you actually what do nurses see in AI. It's so very different perspective than me, right? Or I just hired Dr. Shyam Vyas. He joined us from Hippocratic AI, where he was basically responsible for most of the existing customers, right? He joined us because he shares the same passion and he's so in us a real care for solving the end-to-end medical tech. I will interview somebody like him. Now, you don't want to interview many people from one company, but my point is the perspective. Get not the entrepreneurs or the engineers, but the doctors and the nurses for whom the AI is going to solve that problem and what motivates them to do that I would have thought would be really good people for you to talk to.
Mhm. That would be amazing. Ali, thank you so much. I had to feel or felt like we had to rush a bit in the end, but I really think I'm really grateful that we had the conversation. I think there's beyond, let's say, the talking about the technology, how it's developed, how to manage I think that part of the conversation was very interesting, how to validate it and have it certified. I think your vision for seeing things long term, and yeah, also taking it step by step, making sure that acknowledging as well the responsibility that you have in this, because you are managing half of real people. And I thought that perspective to me was refreshing. In we take things step by step, we acknowledge the regulatory complexity of it, the challenges that we have, but we're pushing for it, and it seems to be very aligned with your vision of making healthcare accessible and yeah, to the broadest population as possible. So I'm really thankful. I think we will have to do a second episode maybe in a couple of years when you guys will be in a different
Thank
place.
you so much. And
So much.
my apologies if I took a long time for each question, but I am of the view that uh, is smaller amount of things talked about in detail is more valuable than lots of short, meaningless answers. So I hope you forgive me for talking too much, but I am grateful to you for giving me the platform to talk to your listeners.
Thanks for watching the episode. I hope you enjoyed it. You can subscribe by clicking on the podcast channel at the top right and watch another episode here at the bottom.